this wonderful opportunity, and thank you for that introduction, ma'am. And let me just tell a disclaimer at the beginning itself. It's not an extensive talk on TMA, but just a few points on a case of atypical HUS or complement-mediated TMA, which I saw about maybe like 2 months back, and the patient is still admitted in the ward. So, okay. So what is thrombotic microangiopathy? Thrombotic microangiopathy is basically when you have a damage to the endothelium due to any reason, and because of that, there is a damage to the endothelium triggering an coagulation cascade, resulting in thrombotic occlusion. And because of the thrombotic occlusion, the microvasculature is damaged, resulting in an end organ damage. And when the red blood cells in the platelet go through this end products of coagulation cascade, we have non-immunological structural destruction of the red blood cells, resulting in microangiopathic hemolytic anemia and thrombocytopenia. So this is what the classical definition says. But many a times we see that in nephrology, we see a condition called renal limited thrombotic microangiopathy. Though there is no hematological parameters to say there is thrombotic microangiopathy. But when you biopsy the patient for a rapidly progressive renal failure, you see thrombotic microangiopathy. So it could be a renal limited thrombotic microangiopathy, which equally qualifies for the diagnosis of thrombotic microangiopathy. Now, coming to this broad outline. So when you see a case of thrombotic microangiopathy, we need to keep our mind open and see where that patient fits into. Is it a primary or a secondary TMA? This is very important because only if you categorize the patient rightly here, then the subsequent steps of evaluation as well as treatment gets right. For example, if you're looking at a primary TMA, the headings in which you should think is a Shiga toxin associated HUS, which was classically otherwise called the hemolytic uremic syndrome. Second is a thrombotic thrombocytopenic purpura, which is ADAMS13 related. Basically, there is a deficiency of ADAMS13 or an antibody against ADAMS13, resulting in a type of TMA, which is thrombotic thrombocytopenic purpura, where predominantly the manifestations could be neurological, and the prominent component is a thrombocytopenia, which is very severe, and the renal dysfunction may or may not be there. So here, it is predominantly a disease of very high mortality. You need to treat it, and there is an evidence of treatment in ADAMS13 deficiency where you can probably give immunosuppression to prevent the antibody formation, or also can give plasma infusion containing ADAMS13, and then the patient gets recovered. Third, and the most important reason for today's talk, is a complement-mediated TMA, or also called the atypical HUS, which is essentially a diagnosis of exclusion. That means to say that we tend to rule out all the other possible causes of TMA. And when you don't really find a reason, then you categorize it as complement-mediated TMA. We also sometimes say that if there is a genetic component, then you call it as complement-mediated TMA, but that's not right, because many a times you have a diagnosis of exclusion that is complement-mediated TMA where all other causes are ruled out. We have a group of conditions called genetic. That means it is genetically mediated, but they don't have a complement genes involved in it. So example is the DGKE, diacylglycerol kinase epsilon, cobalamin deficiency, INF2, etc. Now, coming to the secondary causes, we are all very familiar with the postpartum or post-pregnancy TMA. We have certain drugs which can cause TMA by various mechanisms. Transplantation, predominantly a solid organ transplantation, or more so with bone marrow or stem cell transplantation. Autoimmune diseases like lupus erythematosus, antiphospholipid antibody syndrome, scleroderma renal crisis can cause TMA. Malignancies, disseminated cancers, and monoclonal gammopathy is one of the other causes of TMA. Last but not the least, malignant hypertension is one of the very common causes of TMA, which we see in our wards. And we are not sure about, is it the hypertension which is causing the TMA, or is it a complement-mediated TMA, which resulted in malignant hypertension and TMA? So I just want to start with this case. She's a 32-year-old female who presented to us with history of gestational hypertension. She had proteinuria, that is the primary reason why she came to us. She had mild renal dysfunction, creatinine was 1.5. There was nephrotic range of proteinuria, active urinary sediments, and we evaluated her for lupus and other autoimmune markers, which were all negative. We did a biopsy. Probably that was not the best biopsy we could get. We had only 3 glomeruli, out of which 2 were sclerosed, but there was segmental condensation of matrix there, and IFTA was about 30%. The IF was negative. So in this scenario, we thought that probably she's having a poorly sampled FSGS. She was started on anti-proteinuric therapy and steroids. This was in the month of May 2023. And then she was on follow-up, but we lost her between about 2 to 3 months prior to the second presentation. And the creatinine, the last creatinine which we had was around 2.5. So this time she presented with greenish discoloration of her toes, sort of reddish greenish. If you can appreciate, I'm not sure, but it sort of looked like as if she had a snake bite. And even she went to the local practitioner, Ayurvedic practitioner, who saw and applied something on the topical application, and it looked like a snake bite, but there was no fang marks. There was no history of any a snake bite per se. And the evaluation also didn't show anything like a coagulopathy or something to suggest that she has got a snake bite or a bite of that sort. She had advanced renal failure. The urine was active. And what is predominant was an accelerated hypertension. The blood pressure was very, very high, in the tune of about 220. She had papilledema. There was a drop in hemoglobin. Platelet counts were normal. Schistocytes were not there. LDH was raised. All the autoimmune markers were negative. The C3 was just borderline low, just maybe like around 80, 82 or something like that. So it was not like a very, very severe low C3, but a borderline C3. Subsequently, we repeated the C3 and was found to be normal. So the provisional diagnosis at this time was probably a malignant hypertension-induced TMA. We did dialyzer and did a biopsy. And the biopsy showed predominantly vascular thrombus. So you had intravascular, the afferent arteriole, there's multiple small arteriole thrombus. You can appreciate the schistocytes here. The vessel wall also had necrosis. The afferent arteriole looks thrombosed. And here you can see some necrotic debris within the vessel wall. So it was the glomerular capillaries were relatively spared. The blood vessels had lots of thrombi within it. And about 5 out of the 18 glomeruli were sclerosed. There was duplication of the GBM, segmental sclerosis, and IFTA was about 50%. So where do you fit this patient? So when you have a patient like this, it is very important to know where do you fit that patient in this logarithm. We rule out other obvious causes like pregnancy, transplant, drug, cancer, vasculitis, etc. from the history and the immunological workup. And the 2 things which is left behind, is it a hypertension-mediated TMA, or is it possible that there is a atypical or so-called the complement-mediated TMA, or a genetic but non-complement-mediated TMA. So these were the 2 differential diagnoses which we wanted to differentiate from. And this is a scenario which is very common to all of us. So what does that tells you? That this patient is probably a malignant hypertension-induced TMA versus complement-mediated HUS. So if you look at the statistics, it's very important that complement-mediated hemolytic uremic syndrome, more than 50% present with malignant hypertension. Now, if you take the other way, in essential hypertension or secondary hypertension, about 15% can present with TMA. And if you took all the malignant hypertension, a small component, less than 3%, also can be attributed to complement. So when the patient presents to you with atypical with a complement with malignant hypertension and TMA, we really cannot differentiate clinically many times between these 2. So this articles, which was published in KI in 2024, says that there are certain indicators which tells you that probably this patient is having a complement mediated TMA. So these are not, this is a scoring system, but this is not a validated tool. The higher the score, the higher the chance that you're dealing with a complement mediated TMA. So if it's a female, you get a score of +1. You have +1s and minus. The +1 favors in the line of a atypical HUS or a complement-mediated HUS, and a -2 or negative tells that it's away from a complement-mediated TMA. So it's a female, less than 45 years. If you have a family history of HUS, there is a short history of hypertension or absence of hypertension, absence of LVH, all tells that the hypertension is not so prominent. If the patient requires dialysis because of that particular event, and when you start treating the blood pressure, the hematological parameters doesn't get better. If the patient had a low C3 to start with, and absence of thrombi in the glomeruli, that means to say that if there is no thrombi in the glomeruli, that is a point against complement-mediated HUS. Now, if you look at this patient, the stars are all the factors which were present in our patient. She was a female, less than 45 years. She had no LVH. She required dialysis. Her hematological parameters were steadily worsening. She had a low C3 to start with, which subsequently normalized, and there was no thrombi in the glomeruli. So in spite of that, we were not convinced that this is complement-mediated TMA because she had a pre-existing renal disease. I understand the biopsy was not the perfect biopsy, but she had an FSGS which was there. And the morphology of that particular disease presentation was not like a hemolytic uremic syndrome or TMA. So in this background, we always felt that it is the hypertension which resulted in a TMA. There's no evidence of the TMA in the last biopsy, and the baseline IFTA in the last biopsy was quite severe, about 50%. Probably the hypertension would have worsened and brought in an acute on CKDs. That's what we thought. But there were atypical features against the diagnosis of a malignant hypertension, the non-recovery, a low C3 to start with, and the leg lesion was not typical of a malignant-induced hypertension because we were thinking, is it possible that that lesion in the skin is a skin manifestation of a localized skin TMA? So this was our diagnosis. We were not sure. If we had eculizumab, probably I would have tried, but we didn't have a confusion because that was not reachable. We did few sessions of plasmapheresis, but with no recovery. The patient required multiple blood transfusions. She was oliguric, and AVF was created, and she was continued on dialysis. Considering a young lady at this age, we wanted to go ahead with the transplant. Now, we saw a patient who had classical hematological manifestations and renal manifestations of TMA. But is it true in all the conditions? This is a data in which is from the French consortium. They took both TMA, both renal limited and with hematological parameters. That means all the TMA diagnosis. And they tried to figure out how much of them was really renal limited out of all the TMA. And out of all the HUS, how much of them was renal limited TMA? And they found out that about 45% of all the TMAs due to various causes were renal limited. That means, and out of that, about 25% were complement mediated HUS. So unlike the last case, when you have only renal manifestations and hematological parameters are absolutely normal, we still need to consider the possibility of a renal limited TMA, out of which 25% could be a complement mediated TMA. So now, why do you need to suspect complement-mediated HUS? Because why do you need to bother? Because it requires further evaluation, because it requires a definitive treatment. If you find the complements are the reason, then you can give complement inhibitors, and that could be therapeutic. Certain conditions you can give plasma exchange. For example, if you have a complement factor H antibody, that antibody can be removed, and the therapy could be very important. The clinical course of the disease changes if it's a complement-mediated HUS being a bad prognostic sign. If we are looking at a live-related transplant, if you have a genetic predisposition towards a particular thing, the donor also needs to be worked up for the same. A recurrence post-transplant is very, very important because different mutations carry different connotation when it comes to recurrence. And the treatment prior to transplant, very similar to Dr. Satish sir was saying, whether you need to give eculizumab prior to transplant, that also depends upon whether the genetic makeup. So coming to the complement system, it's also important that the classical and the lectin and the alternate pathway we have. The classical pathway activated by the antigen antibody complex, lectin by the carbohydrate of the bacteria. And the alternate system is a very slow system which gets triggered. And then once it's triggered, it gets activated very, very fast. So the classical gets off started, the C3b is formed, and the C3b in turn activates along with the help of factor B, D, and propidin, stimulates more C3 to become C3b. And the C3b goes down and it facilitates along with C3b, BB to cause C3 converters and the membrane attack complex. Once these regulatory factors are in, B, D, and P will promote more complement activation, and it causes more membrane attack complex. And then you have the endothelial damage, the platelet adhesion, and fibrin formation. So it's also important to regulate the system. And then hence we have the factor H and the factor I, the complement regulator 1, and the membrane cofactor protein MCP. These are all regulator or the negative inhibitor of this loop, because this is an auto-regulated loop in which the C3b will cause more alternate complement activation and then more C3b, and then hence the complement activation. So the factor I is an inhibitor factor, which along with cofactors like factor H, CR1, and the MCP will inhibit C3b, whereas the factor B and D and P are amplifying loop, causing more in C3b production. So this is how the activation is inhibited. So you have C3b, the factor H along with the factor I or MCP or CR1 will break down or inhibit the C3b to IC3b. Similarly, the decay accelerating factor will inhibit or break down the C3b-BB into C3b and BB. So the C3b-BB is broken down and hence the pathway is broken. So we have inhibitory factors and you have the amplification factors. If you have a loss of function of the inhibitory factors like factor H and factor I or the MCP, you have complement-mediated HUS or atypical HUS. You have gain of function of the amplification loop factors, you have atypical HUS. So the factor H is the most commonly lost function, around 30%. Factor I is about 15%. The C3 is the third more common when the gain of function is there around 10%. And the starred ones are the ones which has high chance of recurrence. The MCP being a membrane cofactor protein, membrane bound protein, the donor kidney gives it to the kidney, gives it, and hence this has less chance of recurrence in the transplant kidney. And the third and the last more common important is the CFH antibody, which is very relevant in Indian population because anti-CFH antibodies will combine with factor H and prevents its activation. Hence, CFH antibody is also an important mutation. Result of a mutation. So how do you evaluate the complement-mediated HUS? You have the complement pathways like the AH50, CH50, and mannose binding lectin, which the ELISA plate can individually activate each component and tells you there is a deficiency or not. The complement components can be assessed, C3, C4. The complement byproducts can be assessed, and antibodies complement to complements can be assessed. So the most important is the genetic studies, which we'll be coming to. So it's also important that you also look for the trigger, because it is not just the mutation which causes the problem many a times, because a surgery, an infection, a pregnancy, etc., etc. So it's also very, very important that you need to find a trigger in addition to the genetic studies results. So how do you do the genetic studies? You can do a targeted gene panel. You have about 13 genes like CFH1, CFH, CFI, the MCP. Then you have the CFHR regulatory genes, the CFB, ADAMS13, C3. Then you have the CFH and CFHR, which are basically deletions and duplications, which are not really picked up in target gene panel. Then you have the non-complement genes. So these are the genes which can be specifically asked for as a targeted gene panel, and you get the results. You can do a whole exome sequencing, and you can also do a familial variant testing in which you find out the one of the family members that are affected by a particular mutation, and then you go back to find out whether the other family members are affected. So in our scenario, we did a C3, which was low, initially became normal. C4 was normal. The CFH was done, which was whether in the normal range. The anti-CFH was negative. The costed about 70,000 and it was done in Mumbai, in Pune, KEM. The whole exome sequencing and MLPA was done, which is MLPA is mainly done to find out the CFHR deletions and duplications, which are not sometimes picked up or which are not picked up in the whole exome sequencing. So all of it was negative in our patient. So a genetic study negative, what does that mean to you? So a global AHUS registry data shows that mutations are seen in only about 40 to 50% of the atypical HUS. And many times there was no documented complement gene variants found. And the most common is CFH and anti-CFH, which are found, followed by CFI and CFB and C3. And even the absence of whether the pathological variants are found or not found also depends upon the setting. For example, in a pediatric patient who presented with HUS, the chance of you finding a pathological variant is high as compared to a secondary HU or a STEC HUS. The patient presenting during pregnancy with HUS, the chance of you finding a pathological variant is high. So although the amount of mutations which are found are just in the tune of 50 to 60%, it also depends upon what setting do you see this patient. So when do you check for genetic mutations? When you have a patient with ESRD due to TMA, younger patients with malignant hypertension. So the malignant hypertension, when they present with a very bad course, non-recovering course, atypical features, then you have to suspect whether you're looking at a complement-mediated TMA. Pregnancy-associated TMA outside help. So you have a patient who's presented with TMA, never had preeclampsia, proteinuria. That patient could be having an underlying complement-mediated TMA. When there's a family history, when you have an unexplained renal failure in patients and family members, you probably have to look for genetic mutations. So now look at if you have a genetic variant, this is how the American College of Genetics reports: pathogenic, likely pathogenic. If you have a pathogenic mutations, then there's no chance that there is definitely a complement-mediated TMA. But you have VUS, variants of uncertain significance or likely benign. This is where the problem happens. And you don't know whether it's actually a mutation which is of significance. So you have a VUS or a likely benign How do you go about it? You see whether these VUS or likely benign mutations are in the main complement proteins like CFHI, CFH, C3, etc. Then it could be problematic. There might be literatures on these mutations before, and if there is an association between these and the clinical manifestations, then it has to be problematic. If this is a mutation which has been all throughout, if this is an area which has been preserved in different species, and if you find a mutation in that particular area, then it could be problematic. If this allelic frequency happens to be very rare, less than 0.5 to 1% in population, it could be pathogenic. And now time has come in which people actually generate recombinant protein with the help of AI. And these protein can be compared with a wild protein to find out what is the functional significance of that protein. So coming to the genetics, usually it's autosomal dominant. The most common mutation is the CFH. The CFHR deletions are very commonly seen, but need not be pathological always. The CFHR deletions can be associated with CFH antibodies. So in Indian scenario, this is a very common conditions in which CFHR deletions are associated with CFH antibodies. And it is not a Mendelian pattern of inheritance. So the penetrance is just 50%. So you need to have the genetic factor. In addition to that, there are a lot of epigenetic and environmental factors which can probably result in the clinical manifestations. Some patients can have about 2 gene mutations also. So we went ahead with the transplant. Mother is the donor. ATG induction did really well. The nadir creatinine is 1.1. But her hemoglobin failed to improve even at the end of 1 month with a normal creatinine. She had iron deficiency, which was corrected. The LDH was 700. The schistocytes were negative. Creatinine stayed normal. So, but at 3 months also, she had persistent proteinuria and she has to be started on antihypertensives. The 24-hour urine protein done was showing 3,500. The creatinine also started creeping up a bit at the end of 3 months. Albumin was normal. There was no nephrotic syndrome. HB was stable. Platelet counts were normal. So we thought probably, are we missing a recurrent FSGS or is it an early ABMR? So we are surprised to see that the biopsy had fibrin thrombi in the glomeruli. There was mucoid intima. There was some amount of segmental sclerosis and a lot of glomeruli were collapsed with ischemic ringling. So this was a graft biopsy. We were looking for FSGS, but there was nothing, but it was an acute thrombotic microangiopathy. And there was no features of CNI toxicity. There was no features of rejection. So the thought process was that this is a patient who had initially had a suspected FSGS because he had hypertension, proteinuria, and renal dysfunction. Then it became second presentation presenting with severe renal dysfunction and MAHA. This was thought to be TMA. And in the transplant kidney, she had isolated proteinuria with renal dysfunction presenting with graft biopsy showing TMA with genetic workup negative and complement workup negative. So the diagnosis here we thought was, is it a recurrence of a complement-mediated TMA or is it a de novo thrombotic microangiopathy? If it's de novo thrombotic microangiopathy, it could be because of antibodies against ADAMS13. Is it because drugs like CNI? Can it be an ABMR with isolated TMA with DSA? Could be BKV, CMV, parvo? Could it be autoimmune? So just ADAMS13, which we all know, this is just basically ADAMS13 cleaves the 1 millibrand factor. When that doesn't get cleaved, you have a big chunk of 1 millibrand factor, which activates the coagulation cascade. So ADAMS13 here, deficiency is not possible. Push at this her age is not possible, but antibody can it be? But the plasmic score, which tells the platelet count has to be very severe, renal dysfunction has to be just mild, doesn't clearly look for her, and it turned out the antibody turned out to be negative. This is also what is done at 7,000 rupees, was done in Manipal. The drug levels were fairly okay. ABMR we did as DSA, it was negative. The CMV, BKV PCRs were negative. Autoimmune parameters were negative. So the recurrence of a complement-mediated HUS are provisionally diagnosed. The treatment, eculizumab, we all know, the treatment is once in 2-week infusion. It acts by preventing the breakdown to C5 into C5a and C5b, hence the formation of the membrane attack complex. And these are the trials which was published in 2013 at the beginning. And we found out in all these trials, the moment you started eculizumab, the GFR started increasing and the complements were completely inhibited. But this was cost was prohibitively high, and the dosages, as per the dosage regimen given in the article in 2023, NDT is about 900 milligram weekly dose for 4 doses, followed by once in 2-week doses of 1,200 milligrams. So each while we try to see how much is the cost was at about 1.5 to 2 lakhs. And the newer trials are coming in to say that it's not a fixed dose. You can actually quantify the level of these drugs in the blood and also to see how much of complement inhibition it happens to give. And then we can taper the dosage for each patient. Our patient could not afford and we could not give this drug. So now if the patient could afford, how long will you give? That also depends upon the genetics and the type of the mutation. For example, if you had a pathogenic mutation, if you have a pathogenic mutation in CFH, CFI, etc., this is a high recurrence chance of recurrence, and hence you cannot stop this drug. If a patient has got persistent FH antibody after plasmapheresis, if the patient's disease has relapsed in the native kidney after you treating with eculizumab, or a recurrence after kidney transplant, these are the conditions in which you really cannot stop the drug. But if you find that there's a variant of uncertain significance, and if you can do some functional and structural characterization of that particular gene, and if you find that these proteins are really benign, then you can stop it after 6 to 12 months. But if you find that the proteins are pathogenic, then you need to give long-term treatment. But there are certain mutations which are actually having low chance.
Dr. Jithu, I think we have to conclude for want of time.
Okay, so I just finish it off. You have the newer drugs. Our patient is actually coming into the stage when there is no genetic variant identified, but biopsy proven TMA in the native kidney. So she has to be on lifelong treatment. We have a newer molecule, revolizumab, which can be given once in 8 weeks, which has to be covered. The meningococcal vaccine has to be given, but we already know. But in emergency scenario, we have to give oral penicillin, azithromycin as a prophylactic antibiotics and continue. So our patients, we give 7 days of plasma exchange, knowing that plasma exchange is only useful for anti-CFH antibody, which was negative, but we didn't have anything else to offer her. And currently, after plasmapheresis, her creatinine is continuing to rise, but during plasmapheresis, it was stable. So the take-home message here is that we need to attempt to look for a possibility of a complement-mediated HUS in many malignant hypertension-induced TMA. We need to have a low threshold for genetic studies, and 40% complement-mediated HUS have no identifiable genetic variants. The absence of identifiable variant or absence of an identifiable variable is not evidence of absence, and hence we need to look out for it. Renal limited TMA is a very common entity, and we need to look out for the same. Worsening proteinuria could be a sign of TMA, and complement inhibitors are the only way